Welcome, ladies and gentlemen, to episode 2 of Beyond the Surface, the Psoriasis podcast. I'm Sophia Lowy. I'm honored to be your host today. We understand from the previous episode that there's no cure for psoriasis and psoriatic arthritis. The good news is there are available treatment options and how to manage the conditions. So today we have Dr. Azura, a consultant dermatologist from Hospital Kuala Lumpur. And we have Dominic, who is also a psoriasis warrior with us today. Thank you both of you all for joining us today, and over to you, Dr. Azura.
Thank you, Sophia, for the kind introduction, and warm welcome to you, Dominic, and thank you for taking time to join us in the show today. So we're going to talk about the second segment is on treatment and what are the challenges that patients may experience while seeking treatment. So perhaps you would like to share with us your journey in terms of treatment. What treatment have you had in the past and what treatment are you on now?
Thank you, Doctor. Thank you for having me here. I've had psoriasis for about 20 years of my life now. It first started with basically lesions appearing, and I've sought treatment on the early days using topical treatments, which is basically applying creams and ointments. And then, of course, throughout the years, the psoriasis tends to get a bit more persistent and worse, and that was when I had approached the dermatologist to look at some systemic therapy, which I then started with acetylcholine, which then helped control the psoriasis. Later on, of course, just about 2 or 3 years ago, I started developing psoriatic arthritis, and then moved on to have the treatment of biologics as part of the way to control the psoriatic arthritis.
Right, so I think you have summarized well what are the treatment options we have available for psoriasis. So it's like what Sophia mentioned just now, even though there's no cure for psoriasis, there's actually a wide range of treatment that we can actually give people living with psoriasis. And it all depends on their treatment severity. So we can broadly categorize them into 4 categories. Okay? So we have the topicals, which are the creams and ointments. And we have phototherapy, or known as light therapy. And we have oral medications, known as a conventional systemic therapy. And the latest treatment that we have is biologics. Okay? So what you have mentioned just now, for example, topical treatment examples are like topical steroid, topical corticosteroid, topical calcipotriol, okay? And phototherapy is not offered by many hospitals. Certain hospitals, a majority of their government hospital would offer those kind of treatments. And oral medication, you mentioned acitretin. Apart from acitretin, there's also methotrexate and cyclosporine. And the latest medication that we have in the market nowadays are the injectables, which are biologics. And you are on biologics, I understood?
That's correct.
Okay, so that is an injection. There are several types of biologics available also, and depends on whether you have skin only or skin and joint involvement. The doctor will tailor it according to the needs. Okay? So those are the treatments that we can offer. Apart from, you mentioned that you've already covered the treatment sequence, but when you first diagnosed, were there misdiagnoses? Were you diagnosed as something else and not psoriasis? And how long does it take before eventually you were diagnosed with the correct disease?
Yeah. Thanks for asking this question, Doctor. I think it's pretty pertinent that I share my experience with other psoriasis patients. In terms of having psoriasis that affects the skin, personally, I had a very fast diagnosis. That was because I had access to a dermatologist. I just went to see a dermatologist, and clearly after 1 or 2 sessions, I was diagnosed with having psoriasis. I would also like to add that from my volunteering with the Psoriasis Association for almost about 15 years, I understand that that's not the case with most patients, especially with patients that do not live in urban centers or close to a dermatologist. Through supporting patients, especially via online means, and having spoken to patients who live very far away from urban centers or dermatologists, they do not necessarily get such a fast diagnosis due to the lack of access to a dermatologist. So I would just like to say that for all patients who are listening to this particular conversation of ours, if you have some skin lesions and they do not seem to be able to go away after applying treatment, I would highly suggest that you try to find your way to a dermatologist to get that kind of diagnosis. Would you agree, Dr. Azura?
Yep,
Yes.
I do agree with you, and I do agree that there is some disparity that exists between the availability of dermatologists, and as you rightly pointed out, the urban area, usually it's quite easy for the patients to seek a dermatologist's opinion, but in more rural areas, it's not as accessible as the urban area. But attaining a correct diagnosis is very important, because if we don't have the correct diagnosis to begin with,
Yes.
it's a bit difficult to institute the correct treatment. So yes, early detection of psoriasis enhance the treatment effectiveness, but diagnostic delay is actually quite common in our country, and it's because of the patient do not recognize that it is something that they need to seek treatment early, and also because of the lack of availability of dermatologists in some rural areas. Yeah.
So thank you, doctor, for giving your insights. I would also like to share that since I'm a patient who has also progressed to psoriatic arthritis, I believe that the diagnosis of psoriatic arthritis may not be so straightforward. And I would also like to say that a dermatologist plays actually a very key role when a patient moves from having just psoriasis to psoriatic arthritis. I would like to say that for me personally, psoriatic arthritis has always been on the back of my mind, because as we had conversations before, may be that up to 30% of psoriatic patients, about 3 out of 10, the word is may, develop psoriatic arthritis. And so as someone who wants to be an educated patient, I was aware of several symptoms that could potentially be the starting of psoriatic arthritis. However, for me, personally, it started with a general level of heightened fatigue. And with heightened fatigue, it's not easy to diagnose specifically that you have progressed to psoriatic arthritis. Of course, I went to see my dermatologist to share the symptoms that I had. Of course, with certain patients that have immediate physical appearances, such as what they call sausage fingers, I think someone like a dermatologist would also be able to see and then thus recommend the patient to seek further consultation with a rheumatologist. Now, for me personally, I'd just like to add, for especially patients with symptoms that are not very evident, it will be very likely that your specialist will require you to go for screening for comorbidities before a diagnosis will be given. So for me personally, I had to rule out other comorbidities, such as whether it was sleep apnea, thyroid, and other issues, which in the end, why this impacts the patient is that it may take many months to rule out certain comorbidities, and before you know it, many months could have passed. So for me personally, I took 12 months before I got a diagnosis. And even then, I did not have any physical appearances. I only had fatigue, and later the pain arrived. So I would also like to share with other patients that I had to go through X-rays and MRIs, and only through the third imaging did I discover my psoriatic arthritis appearing. So my final message to patients would be that be assertive with your doctor if you feel that you have a condition with your body that's not detected, but be assertive and be collaborative with your doctor to pursue imaging in order to find where that particular psoriatic arthritis area could be. And I would like to ask Doctor, being a dermatologist, would that be also the professional protocol to ask your psoriasis patients to consult with a rheumatologist, since it is quite well known that psoriatic patients, there are a cohort that could develop psoriatic arthritis? Yes.
Thank you for sharing your journey, and the fact that you had to go through quite a lot before eventually being diagnosed as having psoriatic arthritis. And yes, unfortunately, sometimes in certain cases, it's not as straightforward as having the sausage fingers, as you mentioned, or once the deformity has already set in, it's actually quite late. Okay, so that's why we want to catch the psoriatic arthritis as early as possible, because once the deformity sets in, it's a bit too late to reverse it. So catching it early is very important, as you rightly pointed out. And in our clinic, actually, we have several tools. It's like a questionnaire that we can ask patients while waiting to see doctors in the clinic, because sometimes waiting to see the doctors can take quite a long time, right? So while waiting, there are like 5 questions that a patient can answer while waiting for the doctor, while waiting to be seen. And that is a good screening. It's not 100% sensitive, but it provides a basic screening as to whether anyone would have a psoriatic arthritis or not. But it's just a basic tool. If at any case we still suspect strongly that the patient may have psoriatic arthritis, which may not be evident on the x-ray. Once it's evident on the x-ray, it's actually quite late already, late stage. Okay? MRI may pick early lesion and ultrasound. Yes, we can refer the patient to rheumatologists, but there are also not many rheumatologists in Malaysia, same as the number of dermatologists. So usually we will only refer cases if we are in diagnostic dilemma or when there's already a clear-cut psoriatic arthritis. Okay, so I do understand the frustration that you may have felt, okay, and you feel there's something wrong, but it's not actually picked up by the physician whom you're seeing. Okay? Let's say if they're on any particular treatment, they do not find it any improvement, or the disease progress despite the treatment that they're on, and then they will resort to traditional or supplementary treatment. And actually there are many of those. If you look at your Instagram, your Facebook account, there are a lot of people trying to sell all those products. Have you ever gone through that track? Dominic, would you like to
Thanks
share
for asking me
with
that
us?
question. Going back a couple of years, I think for me, when I got diagnosed, I was considered a young person in the workforce. Of course, biologics were just introduced then. As a young person with a graduate salary, I knew that biologics would provide a very good efficacious treatment. However, the price tag of then about 50 to 80,000 ringgit a year would be very prohibitive. What more to a young graduate person? And even today, biologics costs about 30,000 to 50,000 ringgit. It is still prohibitive to a young person. And that's why later we will talk about how possibly we could see if we could have more advocacy to make biologics more accessible. Now back to the question about alternative treatment. Since very efficacious treatments are prohibitive in terms of price, I would like to share that many patients, once their psoriasis starts to be widespread, imagine having psoriasis on your face or your hands and interacting with co-workers or at school. Immediately your emotions and your reactions from people would start to follow. And that creates, in a sense, emotional disturbance on the patients. Patients do get desperate in order to find a solution. And when you do not have access to efficacious treatment, I think it is also a scenario where people who are in desperation, people give alternative treatments and traditional treatments, and then you tend to want to try in order to quickly solve. Now, as with most advice that we give to psoriasis patients from our Persatuan, we help patients to navigate through such situations. And I think please either approach the Persatuan Psoriasis Malaysia or the Persatuan Psoriasis within your state. Speak to other patients so that you'll be able to navigate whether an alternative treatment or traditional treatment could potentially be good enough, maybe not as the main treatment, but even a complementary treatment. I'm not saying that all traditional or alternative treatments are bad, but I am very sure that there are some where providers of such treatments will want to make money as quick as possible and be able to get these treatments to you. And we have also heard of cases where some of the treatments, for instance, in a pill form, may actually contain steroids. So they actually work for a short while.
Even methotrexate?
Yes, that's correct. They may work for a short while. You do not know what the ingredients are, but in the long term, they don't work. So again, meet more psoriasis patients, especially through the Persatuan, and through the stories of other patients, you can be helped to navigate through this particular topic. Yeah.
Yes, I think what I would advise anyone living with psoriasis is be careful because the claims or the testimonials will say my skin will get better after a few weeks of using it. Just be careful because we don't know what is the actual contents, whether it's topical or oral formulation. It may contain a high amount of steroid, and hence the reason why the joint symptoms and the skin get better. And some they could probably add even the medications that we give. But whenever we give, for example, methotrexate or acitretin, we will always advise patient in terms of what they need to avoid. For example, like acitretin can't be taken in pregnant lady who are in the if they want to conceive a baby, it will be very hazardous to them. Same with methotrexate. Okay, so we will always advise them as to what are the precautionary measures. So be careful. There are a lot of people who want to, they appear that they want to help you because, yeah, nobody likes to have like red patches on their face or the hands where it's visible. So they just, maybe their intentions are good, but just be careful because we don't know what is the actual ingredient inside those medications.
That's right.
Okay, so the other thing I wanted to ask you, you were on quite a lot of treatment already. Did you find like any challenges, for example, like topical treatment, oral medication? Is it difficult to apply, like the greasiness of the medication and oral? Have you ever forgotten to take your acitretin? And you're also on biologics injection. Is it
Yes.
painful, and any challenges you face in terms of treatment?
Thanks for asking that question, Doctor. I'll start with psoriasis. In the early days, we had to use topical treatments such as coal tar. Maybe could you share with us whether that is still
The
used today?
smell. Yes, we still use
used today?
coal tar, and I do understand that the smell can be quite bothersome to some patients. Does it bother you?
Yes. Not only was the smell very strong, it was very messy indeed,
Yes.
especially when it's oily, it stains your clothes. So those are some of the challenges with some of the earlier treatments. And then I think with most psoriasis patients, evidently you will start with creams, being creams as well as ointments. I think through the years, patients have learned that creams tend to work better in the morning because they don't mess up your clothes. Ointments tend to stay longer, and then you use it more when you're at home. So those were the challenges that we faced, but over time we had circumvented it. Of course, there were other challenges that most patients will agree that if your psoriasis is very widespread, you usually will use a cotton bud and you'll spend half an hour in front of the mirror trying to play jigsaw puzzle with all your psoriasis patches in order to finish applying all your creams. So that's indeed very
I think the
time-consuming. Yes,
it's definitely a factor.
Yeah.
How long does it take you to
anywhere
finish
between
applying?
10, if I'm having a very bad flare and it's mostly on most parts of the body, it'll take anywhere between 15 to 30 minutes before I go to work. But on days without flare, but still about 10 to 15 minutes to apply.
So it does put a toll on the patient's time. I mean,
That's
imagine
correct.
trying to get ready for work or coming back to work and you need to cater your family. So I think extra half an hour
That's
times
correct.
2 per day.
Yes. So a dermatologist then advised me to say, let's try to get your widespread psoriasis to be more controlled, and that's where the systemic or pill or oral medicine comes in. And once you have something like MTX or acitretin, whereby you will not have such widespread, then it helps with regards to lesser space to apply, and then you use a combination therapy. As Doctor, maybe you could share, is combination therapy such as having an oral as well as topicals quite common?
Yes, we usually combine both topical and oral because it has a better efficacy. Even if they're on oral medication, we always advise them to continue with the topical treatment as well.
Yes.
What about injection? Do you find that painful?
Yes. So
Do you self-inject?
Yeah, that's actually a very good question. So in the early days, I think with most patients, you would actually go to the doctor to get the injection done because handling a needle is not something that most people are comfortable with. But with the advent of self-injectable pens that have just come onto the market, it's really very easy to administer biologics. Basically, I keep my biologics in the fridge. I just take them out. The dermatologist or the rheumatologist would teach you to inject them. And they're not really that painful. It's just like an ant bite and very easily administered by patients.
All right. Good that you're not needle phobic.
Yes.
We have some patients who are scared of needle, but the good thing with this, all the new pens, you can't really see the
That's right.
needle.
Yes.
Yeah,
It's designed that way.
It's designed nicely so that you don't actually see the needle. So once you inject, and you can actually just dispose it, preferably in a sharps bin. Okay, but actually the sharp part is not actually visible.
That's
so
correct.
It's actually quite safe to dispose even in a normal bin.
Yes, I think with most patients, we would also ask you to responsibly just return those to either the pharmacy or to the doctor, where they have the proper facilities to dispose of such needles.
So I can see that your treatment works because I don't see any
Yes.
patches of plugs on your skin now.
I think just to add one more challenge would be that for people who have psoriasis, if you are able to assess biologics, you will not have to worry about the skin part of your predicament. Having said that, biologics, it is up to the individual of the patient. They could work for a year, many years, but we do have, I think in your experience, doctor, some patients will find that the biologics may not last many years. For instance, myself, I see that some lesions have started to come back, although very minimal. I continue to hope that my biologics will work for a long time. But also, I'm very hopeful that new biologics, with the latest innovation in scientific technology and medical technology, we are always able to switch to newer biologics, or even the small molecule pills that I'm sure you're very familiar with.
Yes, there are a lot of treatment that's already been developed but has not come to Malaysia yet, and there are also a lot of clinical trials that's going on at the moment. So we are very excited to eventually see what's the outcome of all this treatment. We have a lot more medications that we can play around with, a lot more to offer patients compared to when I was a junior doctor 20 years ago. We don't actually have many treatment that we can offer to patients. But now with the advent of biologics, and as you already mentioned, small molecules, those are the newest agent that we have. Hopefully one day we are able to, the aim, of course, we want to cure it, but at least to maintain the period of remission for longer. And like what you mentioned, you hope that the biologic lasts for a longer duration. But yes, we do experience a patient experiencing secondary failure with the biologics, but we have other biologics that we can offer them.
Yeah, I'd like to add that it's also a very hopeful time for most patients. Two issues that we at the Persatuan Psoriasis look at would be, one, access to treatment. As mentioned before, having out-of-pocket expense that is about $30,000 to $50,000 a year is actually a key challenge to most patients in Malaysia. So having accessibility to biologics is very important. We have heard new announcements by Ministry of Health talking about new financing opportunities. We know that these are just in the initial stages, but Persatuan Psoriasis Malaysia would very much like to be a stakeholder with the Ministry of Health and the Government of Malaysia to discuss about possible avenues where there is a better accessibility to such expensive medicine, but very efficacious medicines for patients. And the second part would be actually to have a wide-ranging options for patients. Doctor, would you agree that because all of us are different, we have different genes, we have different makeup genetically, that not all patients will react the same to a particular biologic, and sometimes because we are not at the age of personalized medicine, as a healthcare professional, you would have to sometimes look at switching biologics or finding the right medicine for your patient.
Yeah. Okay. We are talking about access. Yes, we know that at the moment the access for biologic is not as wide as we would want to be. We have many more patients who should be on biologic, but unfortunately because of the cost, we are not able to give all patients, all the deserving patients, the treatment that they should be having. So hopefully we are able to do that in the future. As you've already mentioned, we look forward to what's going to happen in the next few years. Hopefully we have more allocation to treat patients with biologics in government, because it's not cheap. Treatment with biologics for one patient will cost roughly between 20 to 40,000 per year, and imagine continuing that for many years. So it's something that we need to look into, because we cannot just look at the price alone. We're going to talk about this in another segment, but I'll just roughly mention that even though the cost may seem a lot, but imagine the amount that the patient can contribute back to the society if they're well. They don't have to take time off work. They are happier, so they can contribute more to the society. So those are the things that we need to look into rather than the cost of the medication per se. Right, so last question before we end this segment. Any issues with communication with your healthcare practitioner? Because I can see that, Dominic, you're very well read, you know what's going on, you probably know about psoriasis more than what the doctors do. Do you find it a challenge to communicate with your healthcare practitioners, and do they listen to you?
Yes, actually that's a very good question. For me, I've had the good luck and good fortune to have a very good professional healthcare providers such as yourself who have been very open to listen to me as a patient. I would like to say that there have been times where a particular doctor may not be very sure of the suggestion that I've given to take a particular route. However, they have always been open to explore. So to share with other patients, I would like to say that please do be courageous to raise your questions to the doctor, as well as possible evidence-based treatments to your doctor in order to be able to be collaborative with your doctor. Dr. Azura, maybe you would like to share. I think there is a term called collaborative consultation, or another term that was used, where a patient and doctor should be jointly...
we should actually decide based on a mutual decision, because whatever I think for you may not be the treatment that... so the target has to be similar. So my target and your target has to be similar. I mean, like, I cannot just be looking at, okay, I want by 6 months, I want your skin to be like this, or your joint to achieve a certain target. Okay, so our target first has to be mutual. Okay, so we have to reach the destination with a combination. The decision to reach to that target has to be a mutual agreement between the healthcare practitioners and also the patient, because we have some patients who want to reach a destination much earlier. Then we have to be a little bit more aggressive. But some, they say, okay, they just want something that is safe, it's not too toxic, they don't mind the little patches here and there. Okay, so we have to tailor the treatment based on the patient's condition. It has to be a mutual decision between the healthcare practitioners and the patient themselves. Because some may not be bothered by a few patches that they have, but some they just want a total clear skin. So it all depends on, as you correctly pointed out, has to be a mutual agreement between both parties.
I would also like to bring up about one more aspect of psoriasis and psoriatic patients, whereby there could be comorbidities and also multifactorial symptoms from patients. As an example, a psoriasis patient could also be going through mental distress. They could also be having psoriatic arthritis where they have been having trouble sleeping, or they've been having, for instance, brain fog, or they've been having pain. So being a specialist for skin, I believe that you would also advocate for patients to have a team of doctors, for instance, a rheumatologist, or maybe a neurologist, or maybe a sleep dentist even for sleep apnea. So having said that, from my experience, most of my doctors have been very open for me to work with a multiple discipline team of doctors, whereby I also get the suggestion or the freedom to seek doctors within the medical group, and therefore manage the comorbidities as interdiscipline. And I've also had the good fortune of where the doctors would then, let's say for instance, the rheumatologist would feedback to you as a dermatologist, as well as my neurologist would then say, please tell your dermatologist that you are taking a certain medication to manage your other comorbidities. And that was the aspect where I would like to bring up. Maybe get your final input on managing multitude of symptoms from different comorbidities.
Yes, we did actually cover the comorbidities in the first segment, but yes, as you rightly pointed out, depression. Okay, so the emotional aspect of it cannot be pushed aside, because it actually plays a very important factor in managing patients with psoriasis. Having a multidisciplinary team is very important, but it's not easy to have everyone to be at the same time. But as long as if the patient needs to be referred to a psychiatrist or rheumatologist, they are referred to the appropriate doctors who manages those conditions. At least it's good enough. It's not easy to have a multidisciplinary where every subspecialty are together in one clinic. Okay, but that is ideal. Okay, but it's at the moment it's we can't have that kind of facility yet. Maybe in the next few years, right? So thank you, Dominic, for sharing with us your experience. Okay, so I think what we have done for this segment, we have covered what are the treatment options that patients can have, even though there's no cure for psoriasis. There are a lot of treatment options that patient can, depending on their severity. Okay, and we also covered what are the challenges that you face, whether in terms of the treatment or whether it's been misdiagnosis or dealing with the healthcare practitioners. Okay, so I think those are the practical points that patients would want to know. All right. So thank you for being with us today. So I think we'll let Sophia to do this summary. So Sophia, would you like to summarize what have been discussed for this segment?
In summary, several issues emerged during the discussion, such as ranging from financial burden of treatment, delays in treatment, problem in treatment compliance, and importance of improved patient healthcare provider agreement on personal goals of treatment. Patients need to be empowered and their voices need to be heard in treatment plans. A defined set of metrics can be agreed upon between the healthcare provider and the patient. Such practices can be incorporated in clinical practice guidelines. On that note, we extend our warmest thanks to our guest speaker today, Dr. Azura and Dominic, for sharing their insights on treatment regime for psoriatic patients. For more information, please reach out to Psoriasis Association of Malaysia, and you can also reach out to them via Facebook and Instagram. Thank you for joining us on this episode, Beyond the Surface, a psoriasis podcast. And make sure don't miss the next episode, and see you soon.